Hello, everyone. I'm going to go ahead and start since I know that the time is pretty tight. So, yes, thank you. And I'm very excited to be speaking with two amazing, brilliant women. So my name is Deborah Rue, and I'm going to speak just for about 7 minutes, and then I'm going to pass it to the next presenter. So, and I'm sorry, I forget if we advance the slides or if somebody else does, but if you can go to the next slide, that'd be great. Assuming somebody else does it. All right, cool. Thank you. My name is Deborah Rue, and I'm the CEO of Rue Global Impact. We are all about disability inclusion, tech for all, artificial intelligence for all. I've been fascinated with the presentations before me, and just really impressed with all the amazing women that Maya has brought together. There's so much talent here. So also host of several shows. I'm very engaged in the UN and really making a difference. And I'm an author and things like that. I don't want to spend too much time on me. Next slide. I believe that society's expectations continue to shift and change. And I think the younger generations, I'm a baby boomer and 61 years old, very proud to be my age. I don't believe that 60 is the new 40 or the new 20. I believe 60 is the new 60, and let's all celebrate it and really celebrate each other as women. But the younger people have really stepped up and said, yeah, we're not going to work with you if you're not making a difference, if you are not including, diverse people in your workforce. We don't want to work for you. If you're not doing the right thing by your customers, by our planet. There's a lot of real important activism going on, and most of my clients I work with are global corporations, and so I'm constantly making sure that they understand this and that they understand that we have expectations of society that's continuing to grow, that it be a completely diverse workforce. And I think some of the other speakers right before us, they brought up some excellent points with this. We also society expect that employers stand for more than just shareholder value and profits. We want you to be profitable. We understand that you need to be profitable to pay your bills, but at the same time, you need to really stand for something and take the time to tell us what you stand for. Don't wait for us to guess what you're doing or to fill in the blanks. Corporations really need to step up and really show us what you're doing. Next slide. I am repeating what some other brilliant people have already said, but we continue to see a lack of diversity in the AI data sets. Most of the information is on white males. We have biased algorithms. There is conscious and unconscious bias happening, and it's happening across the board. There were some diversity groups. For example, the woman from Spain was mentioning being left-handed. Well, everything's created for right-handed people, and actually, often left-handed people die before right-handed people because technology and tools are not created for them. So really understanding what it means to be truly human, I think, is the opportunity that we have here. We know about racial, gender, ethnic, age discrimination. It's just really unfortunate. And then I thought it was very interesting, the point that Alex was making about the voice, the differences in the voice. I hadn't thought about that perspective. So I think it's so powerful that we're all coming together to talk about all the different ways that we want to make sure that our intelligence is programmed and grown so that it benefits humanity. I think there's also a lot more opportunities using social media platforms like YouTube and TikTok to gather data about how society is really responding and acting. So I believe there's societal awakening happening, and I think programs like AI Women in Ethics are continuing to accelerate who we can be as human beings. Next slide. I'm not going to spend a lot of time because other speakers spoke about this before me, and I'll make sure the next two amazing women have more time, but we have to do better with the diversity intersectionality. I often see only white women like myself speaking. Now I'm an older white woman now, so I go into another category. I also am a person that identifies as having invisible disabilities, ADHD, and often, depression, sometimes severe depression, which means I'm a normal human being. But there's so many moving parts, and all of us need to be included if we're really, really going to really make changes in the world. I really believe that we're all stronger together, but I often see that the people that are up on the stages look like me. They're white, hopefully they're women, but we need to do a better job of making sure that the microphone is handed to other people so that we can really make sure that we're talking about this in really grounded ways. Next slide. As we do these things, we continue to close, we want to close the digital divide. Unfortunately, the digital divide is, we've seen how much work we have to do during the COVID-19. In the United States, 40% of children could not effectively be educated because of the lack of connectivity, the lack of good technology, the lack of, there's just so many factors. Digital inclusion, which I don't always hear being talked about when we're talking about disability inclusion, is critical, because once again, if we don't have the right technology, we can't afford the technology, we don't have training on the technology, we don't have connectivity, everyone loses. I'm hoping for 5G that will really help continue to bring access to us. I live in Virginia, in rural Virginia, and we don't have good access to internet out here. So I have to pay triple what my neighbors that live about 20 miles away from me for the fast speed that they get. So it's still a problem everywhere, not just in developing countries. Next slide. And I wanted to keep it tight because I want to make sure, but I want to continue to say representation matters. It can't always be people with invisible disabilities or people that you can't tell what diversity group they're speaking from. We need to make sure that it's more diverse. So thank you to Mia and for everyone that's part of this. And I will turn it over to the next wonderful speaker.
Thank you, Deborah. Hello, I'm Chavi Chahan. Personally, I'm a mother. My daughter Mohana is turning 4 today. Thank you, Mia, for the shout out at the beginning of this event. And thank you all the attendees for your warm blessings. She's one fortunate kid. Professionally, I'm Director of Scientific Outreach at the American Society for for Investigative Pathology, Ethics Advisor for the Alliance for Artificial Intelligence in Healthcare, and Policy Expert at AI Policy Exchange. Today, I would like to focus on data disparities that have been impeding AI-based innovation in the healthcare sector. And thank you, Deborah, for setting up the stage so nicely. COVID-19. Even my toddler is familiar with this word. This pandemic has touched our lives in unimaginable ways. Please advance slide. Oh, yes, this one is good. Can we go back, please? We went, yeah, thank you. The initial trends of the pandemic in Italy suggested that elderly are at a higher risk of contracting as well as dying of COVID-19. These data are also compared in New York, the initial US epicenter of this pandemic. Despite the pressing nature of scientific collaboration that's needed to combat this pandemic, patient data safety and privacy concerns surrounding AI-based tools in healthcare have totally stymied this collaboration. Next slide, please. The data from APM Research Lab show that African Americans, Indigenous Americans, and Hispanics are at a higher risk of contracting COVID-19 and dying from it among the US populations. However, the current electronic health record systems do not adequately capture racial and ethnic diversity in local communities. The CDC reports that these populations have limited access to healthcare. They represent more frontline workers who are unable to work remotely. They're already struggling with education, income, and wealth gaps, and they often lack appropriate housing conditions. Now, these vulnerable populations are also reported to be at a higher risk of having underlying comorbidities due to their several socioeconomic factors, making them further susceptible to COVID-19. Advanced slide, please. What we now have are pools of high-risk populations who have limited access to healthcare, which results in inadequate representation in data sets built for contact tracing to control or contain the spread of COVID-19, as well as testing to limit the spread by timely quarantining. Shockingly, the currently undergoing clinical trials for COVID-19 continue to either exclude or underrepresent aging populations and minorities who critically need to benefit from these vaccines and drugs. The lack of fairness and diversity in COVID-19 related data sets are bound to cripple the use of AI-based tools in this particular context. Next slide, please. There is an urgent need to make healthcare data sets inclusive for COVID-19 to account for underlying disparities, especially as they relate to healthcare access, utilization, and patient treatment. These fair and inclusive data sets can then be used to train AI, to develop, deploy, and scale AI-based tools to allow global collaboration to combat this pandemic. Next slide, please. The AI-based models in the healthcare sector that are trained on fair and inclusive data sets should then be built on a strong foundation of key ethical frameworks, the frameworks that each one of us had been pointing out to throughout the course of the sessions this morning, the frameworks that are safe, that are secure, fair, inclusive, diverse, explainable, scalable to combat a pandemic, global pandemic like COVID-19, transparent, trustworthy, and above all, humanitarian. Thank you.
Hello everyone, I am Ayushi Tandon and I hope you all are learning because I am learning and enjoying till now. So I'm Ayushi Tandon, I'm doctoral candidate in Information Systems area at Indian Institute of Management, Ahmedabad, India. And I'm doing research on use of electronic medical records for women health and technology in education. But I'm also Indian. I belong to a country with colonial past and my grandparents have lived in the colonized India. My parents graduated in India before globalization became a known word. And that is why I have grown up being disciplined by categories that are Eurocentric and also imbibing the categories rooted in religion, spirituality, and historical culture of India. India as a nation is part of many ongoing land, water, and border conflicts. But because of my birth, I'm very less impacted by such discourses in my daily life. I belong to a state where I'm demographic majority. I'm also identified as upper caste, conveyed by name. High chances that AI trained on Indian dataset also knows or would know that I belong to the most common religion in India. To quote Isabel Wilkerson, the hierarchy of caste is about power, which groups have it and which do not. And that is why I make few of those privileges explicit in the slide. These are the privileges that I have in Indian society and also privileges my ancestors and family members had, which is transferred to me as social, cultural, and economic capital. I also self-identify as cisgendered, heterosexual, thus subscribing to dominant norms. Our society and world is patriarchal and gendered. India is in transition phase, and in this transition, I do challenge some norms. I am 30 plus, unmarried, I'm having polycystic ovary syndrome, and I could avail some institutional support for my condition. Why I'm telling you all this? Because all this informs what I will be telling and sharing in next few minutes. Now, what is this presentation about? My attempt in next few minutes is to encourage you all to critically reflect on the stance that you take while doing AI and ML analytics. The focus of this presentation is on data that you use for training the algorithm. My methods are conversational interviews, ethnographic interviews, participatory and non-participatory note-taking, very unconventional, predominantly in AI ethics domain. There are many people engaging with whom and reading their work. I'm learning and trying to articulate my own points. Those names are there on the slide. And you can take a snapshot of this slide and follow articles of these people. You can tweet about the slide. Next slide, please. Ria was visiting hospital with her mother. Her mother told me that she was worried about Ria as she was reaching marriageable age. She was studying overnight, gaining some weight, and her menstrual cycle was delayed. Doctor prescribed ultrasonography diagnostic test to Ria to confirm or reject the suspected polycystic ovary. Doctor explained Ria verbally to take care of her diet, to do yoga and meditation. Sia was also doing her undergraduate studies in the same city where the hospital was. She was visiting the same hospital post-lunch with her friend Sunny. Let's call him Sunny, anyhow I'm using pseudonyms here. He drove Shia to hospital and they both had to miss post-lunch lectures they were studying. Sunny also decided to accompany Sia inside the consultation room. Sia told doctor about gaining some weight and her menstrual cycle being delayed. Doctor immediately asked Sia about being sexually active. And then doctor prescribed ultrasonography diagnostic test. Sia came out of the consultation room worried, and since I was there in the hospital lobby, she shared with me, what am I going to tell my mother? What am I going to tell my father? I'm not doing anything. By not doing anything, she was trying to justify me also that she was not sexually active. We control sexual activities of women, unmarried women, more so in urban society. Why doctor has given me this diagnosis? She was asking me again and again. Doctor had not explained her anything. If Indians are there in this session, they can tell you more and we can discuss about this in Basecamp and over Twitter. Look at the screen. Ria and Sia, they are two women. Both went to see doctor. They get consultation records. Both have same records. You can see on the screen, but they have different story. And story matters because records look alike. What this record hides? It makes invisible the stress of education system, patriarchal and the gender biases in the data. Next slide. The data is not problematic in its primary purpose because it's created just to communicate hospital department about the test, manage payment, nothing else. But proponents of digitalization in healthcare urge for use of electronic medical records for AI/ML model, applying deep learning for electronic health records, prediction and prevention of error in diagnosis. But in all these data, contextual details are missing. Next slide. So what we do? We cannot and we should not use this data without understanding the purpose, without discussing with people who are creating the data, for whom, about whom we are creating the data. We need to know the data story, data origin story. We should listen to people like Stephanie Dinkins telling value of small data, researchers talking about data gap, data poor, and challenging the notion of big data as not the only rich data. So in summary, what is there for AI analyst? What they must know? They must value cultural insider, domain expert, stakeholder discussion, diverse representation. That is what we are trying to discuss here. We need more conversation on value of small data. We need data origin stories. Next slide. We need your stories, your voices. So please join us and share your stories. Thank you.
Thank you so much for sharing that. I know it's not very easy to share these personal stories, but the purpose behind these sessions is to make sure that everyone gets a chance and a platform to tell their own stories and not have someone else